I'm sorry, was someone going to speak? And I'm just going to ask if everybody could please mute themselves. Thank you.
And I'll do it too if people are muted. So go ahead, Lauren. I'll take care of it.
All right. So welcome everybody. My name is Lauren Grablick. I'm part of the Novice Simulation Committee group. And today I'm going to be giving a quick presentation on designing simulation research. So before we get started, I just want to kind of go over the agenda for the meeting today. So we'll recap our meeting from July. And then I'm going to be giving this summary of this paper called Designing and Conducting Simulation-Based Research, which I think you guys will really enjoy because I think it's, it's perfect for this group. It's a great foundational paper for some of the principles that guide simulation research. So it's good for a novice group. I've used it a lot in my research, and I think if you haven't seen it before, it's a good resource to have. I really do hope that everybody please just like jump in at any time if any of the things that I bring up spark any questions or comments. I would love for this to be more of an interactive discussion rather than a didactic lecture, because we're all kind of teaching each other here. And then we'll go over some of the upcoming events. So last month, we did a journal club where we reviewed 3 papers going over rapid cycle deliberate practice, which is a really great learning tool that we use in simulation to teach. And I think it's actually a nice segue into the paper that we're going to be discussing today when we talk about different kinds of simulation research and investigating different kinds of ways to use simulation either as a teaching tool or as a research principle on its own. So with that, yeah, unless anybody has any questions, I'm going to get started reviewing this paper. So if you look at the list of names here of the researchers who published this paper, there's a lot of familiar names because many of them, if not all of them, are Inspire members. And they came together to give this paper in 2014, which was published in Pediatrics, to kind of go over foundational constructs of like when we think about designing simulation research, what are some of the things that we absolutely should not forget or really consider in our construct. So the first thing that the authors do is they make these 2 primary categories of what they consider the big buckets of simulation-based research. So the first one is looking at the efficacy of simulation as a training methodology. And so that usually encompasses more things like simulation-based educational interventions. And in my mind, that's kind of where I see all those papers on like rapid cycle deliberate practice, where we were looking at, this is a new kind of way to deliver simulation training and how efficacious was it as a learning tool. So basically this one is training assessing how well simulation can improve your knowledge and skills for medical professionals. And then the second bucket is using simulation as an investigative methodology. So this is more not learning how to use simulation to teach, but rather using simulation to answer questions that we would not be able to do so ethically or safely in real life. So it's using simulation as an investigative model. And when we think about it in terms of an investigative model, usually we're using it to kind of identify latent safety threats or assess kind of these human factors that can affect performance in real life. So I think a big one that I like is the technology-based one. So this category, so you could think about, like, let's say we've designed a new type of medical technology and we want to see if it improves our ability to take care of patients. But like you wouldn't design a new drug and just hand it out to the masses. You have to do your clinical trials. So I kind of think of this as like the clinical trials for medical technology, where you can apply this new technology through simulation and see if it improves outcomes without risking using it on a real patient quite yet. And then there's some of the other, kind of more softer, like systems factors, patient factors, teams, looking more at like flow and those kind of things, and the way it affects your environment. And one of the things that it's really used for commonly is identifying latent safety threats. So if we run all of these scenarios in simulation, we may be able to identify safety threats in advance of them happening in real life, and hopefully be able to intervene on them before they actually cause an adverse patient outcome. So simulation in general, it has these huge advantages in terms of when you're designing research, it's kind of special to simulation that you can so well standardize what you're going to be researching. So you can standardize the patients, you can standardize the environments, but in order to take advantage of that advantage, it requires very rigorous study design, because what you cannot predict is you cannot predict how the participants in your simulation are going to respond. So the people are kind of like the question mark factors there, and you don't know what path they're going to choose when they're presented with a simulation scenario. So in advance of presenting the scenario to your learners, you need to think about what are the potential outcomes. I have one way of approaching something, but if you run simulations yourself in the past, you may have been surprised and said, oh, I didn't think anybody would think to do that, and they go down that path, and now what am I going to do in the moment? And the reason that that's important in research is because sometimes if people make a choice to do something different in a scenario than you had anticipated, it can send the scenario down a totally different path than you anticipated, and that can disrupt your study design, and you can have a lot of variation. So what we're going to talk about today is what to think about before you start your study to help minimize that variation and to have it like a rigorous and standardized study design. So critical design elements would be to make sure you detail your educational group and your control group, because like any good study, you have to have a control arm, you have to have an interventional arm, and usually that's intervention in our scenario is usually educationally based. When you're designing your study, you really want to think about ways to mitigate threats to internal validity. And so that's like what I was saying before. What's the like craziest thing that someone's going to choose to do that you need to know what you're going to do in that situation, and then just minimize those confounding variables. And one of the things that they highlighted in this paper, which I've never really dealt with before, I have participated in, but I've never had to think about it for myself, is standardization for multi-center studies. I've participated in multi-center studies before, but I never really thought about what a lift that is to manage standardization across sites, because you may pilot, you may design things that are going to work in your center, but once you're thinking more broadly about simulation studies that are going to involve multiple different hospitals in multiple different places in the country or potentially across the world, they may have very different access to materials, and that's going to be a big threat to the validity of your study if you don't think about that in advance to standardize it. All right, so starting at kind of the most fundamental level, what simulator are you going to use? And when we're thinking about what simulator you're going to use, we have such a wide variety from very low fidelity to very high fidelity simulators. And the fidelity of the simulator doesn't necessarily mean that that's going to confer a particular degree of like confidence in your study, or like it doesn't need to be a very high fidelity simulator to make it a very special study. What all that matters is that, is your simulator going to provide the outcome that is of interest to you? And so, if let's say you wanted to look at chest compressions, you may want to choose a simulator that has the ability to provide you outcome data from like the depth or the rate of chest compressions. And if it can't do that, how else would you measure it? and thinking about your outcome of interest, making sure you're choosing the right simulator for your study. The next thing that you would think about is like, how can I maximize realism? And the reason, like, this is a little bit less important than like the outcome of interest, because ultimately the hard data is going to be probably the most important thing. But for your participants, the more real it feels to them, the more likely this is going to translate to real life, because ultimately, you know, what we can prove in simulation is great, but the way it translates to real clinical outcomes is extremely important. So the more realistic you can make it feel for your participants, the better your outcomes are going to translate. Then we think about our scenario design. And so again, thinking about how you're going to standardize your delivery. So when you think about different groups, are they made up of the same kind of people? Is it the same kind of level of learner? Again, minimizing the variation around the outcome of interest specifically. So they may choose to do different things at different points in your scenario. And does that matter? Is that going to affect specifically what you are looking for as the outcome of interest in your study? And then ways that you could consider controlling this would be, you could consider controlling the duration. So let's say you give them a fixed amount of time. So for me, I did a study in residency where I was looking at pediatric residents' responses to like rapid response. And the way that I controlled variation was I said, they're going to have a certain amount of time, and at 3 minutes, this is going to happen, and at 5 minutes, this is going to happen, and then we're going to have the study end. So that would be controlling duration. Then the other thing you could consider doing would be controlling responses. So let's say instead of saying at 3 minutes, the blood pressure is going to drop, at 5 minutes, they're going to go into cardiac arrest, you would say, if they don't give fluids at this amount of time, then the blood pressure drops. If fluids is given by this time, then the blood pressure responds. So controlling your outcome based on responses is probably more realistic, but it may increase the variability in your outcomes. So you got to think about what is more important to you. And then another thing to consider is controlling the confederate behaviors, because frequently we have people in the room that are not the participants or the learners, but they're there to facilitate the progression of the scenario. So you may have someone who is playing a nurse or parent or whatever. But you have to realize that there's different levels of training, and to be a good confederate requires you to be able to improv to a certain degree and respond to how the learners are gonna act in a scenario, you know. So, but again, you don't want them to improv too much, because then that enters a degree of variability. So things you may consider doing would be giving your confederate standardized verbal cues. So like, if by 5 minutes your participant does not have a blood pressure, you may think to say, I don't know, the mental status is a little off, or something like that, something to cue them if that's what you want. Or you may tell them, I want to know what the participant is going to do, and I do not want you to provide any verbal cues to them at all. Or you may say, you know, you may prompt them to say, if they say hang fluids, you want to know how much fluids do you want me to give? And a good way to kind of get through these inevitable bumps in the road is pilot testing. And the first time I ever did a simulation study, this was kind of like a new concept to me. And you know, simulation studies in general are just, they're big lifts, they're big asks. And I was like, oh my gosh, now before I even start the study, now I have to find a few more volunteers to do pilot testing. Like, but actually it's so important. And running that scenario, even like once or twice with a couple people, you're going to find these surprises that you're like, oh, I didn't even consider that I should be thinking about this potential bump. And it allows you to smooth it out in advance. So it is a little bit of extra work, but very important, and I think it'll really help. Next, you want to think about physical realism. So that basically is talking about how realistic is your mannequin. So you can think about does this mannequin, like if I'm doing a case of respiratory distress, does this mannequin show retractions? Does this mannequin have a capillary refill? Is there moulage that I could use on this mannequin? And then also that realism will extend to their environment as well. So if I'm doing a study that's supposed to simulate the emergency department, but I'm running it in a basement somewhere that doesn't have all the equipment that the emergency department would, inevitably you're going to get participants who say, well, they kind of like they break the fourth wall, I guess you would say. Like they're like, well, if this was real life, I would ask for blah. And it's like, well, I want you to pretend that this is real. So I want you to do what you would in that environment. So to kind of like prevent that from happening, because when people start acknowledging that this is not how I would perform in real life, it can really affect the feel of a simulation. Try to maximize that physical realism in advance. You say, well, I have the bamboo bag here, and if you want to use it, you have to set it up and use it. Then the authors went on to talk about things like conceptual realism and emotional realism. So conceptual realism refers to if-then relationships. So that kind of goes back to what we were talking about before. You know, if I give fluids, the blood pressure responds, and you know, but again, that again can change the variability in your outcomes, but it will make it feel more realistic to the patient. But then if you're going to use conceptual realism, then you have to be prepared for, you know, again, what if they choose to use a medication that is something that you never would have dreamt of using in that situation? How are you going to make that patient respond? Are you, you know, if that's something that would have been devastating to the patient, are you going to have that patient code in that scenario, or how are you going to respond in that moment? And then emotional realism, this can be kind of like a huge topic on its own, but it kind of goes back to what I was speaking to before, when they break that fourth wall and say, you know, you know, if it was X, then I would do Y. So how would you manage a learner like that? How would you manage a learner who is disengaged? Or, you know, one time I was taking a debriefing course, and this is something I had never experienced before, but I think it definitely happens. Like, how would you deal with a triggered learner? So like, let's say you're doing a simulation on, you know, like a severe trauma, or maybe like giving bad news or something like that. How are you going to deal with a learner who maybe this like hit a little too close to home for them, and maybe they're not behaving the way you would have expected, or maybe something behaving potentially unprofessionally? How are you, the facilitator, going to manage it, and how would your confederates in the room manage it? And you know, I think that's where the people in the room, the confederates, they have a lot of control in those situations to kind of dial up or down the emotional realism to kind of control variability for your outcomes. And then the next thing the authors talked about was debriefing. And for all of us simulation enthusiasts, I think we can all say that educationally speaking, debriefing is the most important part. But when it comes to research, you may be maybe not as important, and maybe even considered optional. So when you're thinking about simulation as like a training methodology, so when we're talking about simulation for educationally based interventions, the debriefing is critically important, because that moment where you stop your active learning, where you're performing the simulation, you're engaging, and then you pause and reflect on what you've done, that has been shown to be where the most learning occurs, and that's where everything kind of gets downloaded and programmed into your brain. So if you're doing a study looking at this efficacy of simulation as a training methodology, the type of debriefing that you're doing is very important. So whoever is going to be running your facilitation process, whoever's going to be running your debriefing, it has to be very standardized to make a valid study. So what debriefing theory are you going to be using? Because there's many different kinds of debriefing theories, and you all want to be on the same page. In advance, if you have it available to you, if you could take a debriefing course, I just thought that was so helpful. It really taught me so much about how adult learners receive information and what's the most effective way to reach your learners. And that what I took was a 2 or 3 day course, and I think they only covered one debriefing theory. And I've come to learn over the years that there are just so many options out there. So the more training that you can get in advance of your study is going to really optimize the data that you're able to pull out of your study. So debriefing theory is one critical thing. Then you want to make an outline of the content that you're going to cover. So when you're writing up your cases, at the end, you should have a facilitator guide where you're going to say, these are the topics that we're going to cover in the debriefing. Because again, you want to standardize the outcomes. So what topics are covered? We don't want to go off the rails and spend, you only have 20, 30 minutes to debrief. You don't want to spend all that time talking about something that's not related to your study. So you want your facilitators to be standardized in what they are having learners take away. You want to think about the environment where that's occurring as well. So are you going to be debriefing in the room where the simulation happened? Are you going to be debriefing in a room somewhere else? Are you going to be debriefing virtually, in person? And when is that debriefing going to occur? Because let's say you're running a study with 3 cases. Are you going to stop and debrief after each one? Or are you going to run all of your cases and then have one collective debrief at the end? If you're running multiple rooms, is everybody going to come back and debrief together? Or is each group going to debrief separately? So all these things to think about in advance. And then if you're using simulation as an investigative methodology, this hurts me a little bit to say, but the debriefing can be considered technically optional. So when I say this, think about if you were using simulation to test a new piece of technology. If your outcome data is, let's say you're using a fancy new Ambu bag and you want to know the volume of breaths delivered and the rate. All of this is kind of objective data that you may be getting out of your simulator itself. It may not really matter to you if you want the soft, qualitative data of what the participants felt about using it. It may, but the debriefing itself could be considered optional depending on your study design. Any questions about anything we've talked about so far? Comments? I'm just going to check the chat really quick. Okay. All right, so moving on. This is another thing that I did not think of until my very first simulation project, and it's actually hugely important. So when you are performing a simulation study, you may want to consider video recording your sessions. And I was very fortunate to be at an institution where they had audio and video recording available to me in each of the rooms. And so I was lucky that I could just, kind of set it and forget it and then review those tapes later. But if you're at an institution where maybe you're bringing your own equipment or they do not have equipment available, maybe you're using your phone or something else, you have to be very cognizant of, where you're going to place your cameras. If you're going to have microphones, where are you going to place those? Again, always thinking in terms of what are my outcome measures? If I'm looking at rate and depth of chest compressions, I want my video to be angled so that I can see that. If it's an overhead video, that's not going to give me the data I need. And then this is also something that you should be doing in your pilot testing, because you may put a camera somewhere and you may go back and you may look at the data or look at the footage and say, oh my gosh, I couldn't hear anything that was happening. And you'll realize you need to put a microphone somewhere else or get a different microphone. And then the other thing you may want to consider is who's going to be reviewing the data afterwards. Is it you? Is it someone who was in the room? Is it someone who's familiar with the case, or is it going to be like a blinded reviewer? And is that blinded reviewer going to require some additional data to understand the full context of what was happening there? And would they benefit from having a visualization of what the vital sign monitor was? So when I think about like virtual simulation, if we're doing it on Zoom, sometimes we'll have one screen that is the participants and one screen that is the vital sign monitor, so that everybody's able to see what the vitals are. If you just have a camera looking at the participants, you may see them start to respond to like stimuli in the room, but you as the reviewer on the end of the camera may not understand what exactly is happening because they're responding to something like a vital sign monitor that you're not able to see. So just things to think about in advance. And then there's some other little soft things. So let's say your outcome measure is time to completion of a certain task. The time is going to depend on what your time zero is. And this was a mistake that I made in my study where I was like, I don't know, time zero is like when it starts. But if you're measuring something to the second, you really need to know definitively, what is my time zero? And this is something that I learned at an Inspire meeting that I thought was just a great little soundbite of information to take forward, is like have an audio cue that announces your time zero. Either like when you're giving your pre-brief to your learners, maybe the sound of the door closing when that facilitator leaves the room is your time zero, or perhaps having like a very distinctive verbal cue saying the patient has arrived, and like that's your time zero, because your video recording may have started minutes or so before like the actual simulation started. So if you're going from time zero on your video, that may not be valid. And then think about the number of reviewers that you're going to have. So how many reviewers, is it going to be the people in your study? Are you going to have blinded reviewers? You probably want at least 2 reviewers independently reviewing to improve the validity of your study. Okay. Yeah.
There's a comment in the chat, just that like lesson learned from collecting data from someone's study was that microphone placement was really important, and then having a backup recording, because forgetting to record one session, which I think is a great point to always sort of have a backup plan. And then there's a second question: what about simulation as an implementation method, such as for intervention or for quality improvement? And so I think you sort of touched on that a little bit on your dichotomy of what we're studying, but just wondering if we could clarify that again.
Yeah, thank you, Lindsay. So just to Suzanne's point about the backup, absolutely. I'm running this study right now that is not necessarily simulation based, but it was like focus group based, and my microphone cut out. And then I did this whole focus group for 45 minutes and I have like 0 data to show for it. And I cannot tell you how flippin' frustrating that is. So if you can have double recording, that is very, very helpful. And then the other comment about simulation as an implementation method for intervention or quality improvement. Yeah, so I think that would probably fall into the category of yeah, I think probably as an investigative method. I don't know. I think it depends on what your outcome is, because if you're saying, if we think about like, let's go back up here to some of our factors. Like if you're saying, I'm implementing this simulation study and I want to see if it, are you asking like, can I show that my simulation intervention has shown a clinical outcome, like for quality improvement, like now my actual patient data has improved because of this simulation study? Is that kind of what you're asking? Is
hello, hi,
then,
Venkat.
Is Dr. Sundaram still here?
Yeah, exactly. So the question is exactly like, say we have some method has been established already in like say we know that particular thing. For example, we transport, like say, a newborn from the delivery room to the NICU. And we know that actually, if they don't reach on time, then that can lead to some poor outcome, like say, bring them actually without any risk of hypothermia while they come to NICU, and then can modify the mortality. So you plan all the like make a checklist and then look at all the items that are essential to prevent hypothermia while transport and reach them safely. So that will be more like quality improvement method. So we're not investigating anything new in this. We know that something would work. So we want to use in the practice. That's what I'm trying to see. Would that fall in a third category, or would that?
So I think like if you were implementing a checklist, I mean, you could collect baseline data, and I don't know that you would necessarily need, like if you wanted the implementation of your checklist to include like a simulation training period, then that would you could collect baseline data, then you could implement your checklist with the training, with the simulation, and then collect data afterwards. And actually what we're going to be getting to in like a later slide is this Kirkpatrick's model of outcome measures. And this, like the evaluation of results, the way it impacts your actual patients, that's like the highest level of outcome measures that you could ever hope for. So I think that would be an awesome study. But I guess the category that it would fall into in terms of efficacy versus investigative methodology, this is more just like kind of like a mental construct. So I think an argument could be made for either in that instance, but I do think that that's a really cool idea. And then Gowrie, Dr. Stevens asked a question about 2 reviewers. So we need to measure our inter-rater reliability for outcome measures. Yeah, so I agree with you. Yes, measuring inter-rater reliability is something that they will look for in your manuscript when you ultimately publish. And how you reconcile differences in reviewer opinion, that's actually something I was going to touch on next. So thank you for bringing it up. I'm going to talk about that a little bit more on my next slide. Okay, so outcome measures. Or maybe it's a little bit further down, but I do promise I will get to your question about inter-rater reliability and how to reconcile those differences. So this is one of our later slides, but it's something that should be in the forefront of your mind when you're designing your study. So even before you design your case scenarios and you go through all the nitty-gritty details of like how you're going to implement it, the most important thing is, what am I measuring? And I kind of think of this like when you're designing a talk or when you're designing a curriculum, you know, what are my learning objectives? When you're designing a study, it's what are my outcome measures, and everything should come from that. And your outcome measures should be relevant, they should be measurable, and they should be associated to the intervention that you're making. So the reason I say this is because I feel like sometimes it's easy to be like, oh, this study would be so cool, and I want to do this particular kind of simulation because I think it's really cool. And then we kind of like squeeze in our outcome measures to fit the study design, but really the outcome measures should come first and your study design should come afterwards. And this Kirkpatrick's model is something that is referenced frequently when people are reviewing papers or presentation abstracts. They look at your outcome measure and see what's the degree of impact. So the most fundamental layer would be learner reaction, so evaluation of reaction. So this would be a study where you say, I have all these learners, we did these cases, and at the end of the cases, the learners filled out a study or a survey, like a Likert survey, and said like, yes, I felt that that was beneficial to my learning. So that would be kind of the lowest level. The next level would be evaluation of learning. So your learners, they participated in a study, before they performed the simulations, they took a quiz and their score was X. After the simulation, their score was Y. And I have shown that they have learned something from this educational intervention. Then the next one, the next higher up would be evaluation of behavior. So this would be my learners, they came in knowing X, they left learning Y, and then I studied the outcomes in the hospital later. And I believe that because of my intervention, I saw this improvement in my patients. And then the highest one is transfer impact on society. So sorry, I guess to clarify, the one before would be the evaluation of behavior. So my learners participated in a study, they learned something and they changed how they acted in a situation. And then the highest category would be my learners changed how they acted in a situation and it benefited the patient, and here's what happened. So those are the layers. And I would say this top layer of like showing actual patient impact, which I think was what Dr. Sandaham had been mentioning, that's the highest level to achieve. It's very difficult, but very impactful if you can. So this is now getting back to Dr. Stevens' question about checklists, integrated reliability and outcome measures. So we kind of touched on this before, but your different kinds of outcome measures, they could involve the simulator itself, they could be observational checklists, or they could be clinical and translational outcomes. So the simulator itself would be things like time to completion, which we talked about, how long does it take them to establish a definitive airway or whatever. Observational checklist. So this is finally getting back to Dr. Stevens' question. So is the checklist that you're going to be using. There's lots of different checklists out there, and this paper actually gives a really nice table of some of the most popular checklists that are out there. And the benefit of using a pre-validated checklist is that you don't have to do the validation yourself. And I think Lindsay was going to maybe give us a little bit of information about what goes into validating a checklist, because that's a study all in its own, and that's a paper all in its own. So if you can find a checklist that is validated and validated in your study population, that makes everything so much easier, because you can say in your outcome measures, you can say in the results section and the discussion of your paper, I've used a validated checklist. And so I can say with confidence that my study results are valid because I used a checklist that's already been published. So in a study that I did, I was using a checklist that was validated. Actually, it was this one, the KidSim. It was a checklist that was validated in pediatric residents to assess team leader performance, which is exactly what I was doing. So it's nice. I can say, oh, someone else already did the hard work for me, and now I just use their checklist, as long as it's contextually appropriate to your study. What I will say is that the checklist that you choose, you should teach your reviewers how to use it. So that was a mistake I made that I would encourage people to not make in their studies. I don't know, I was like, oh, it's a checklist, here you go. So I gave it to my reviewers and I was like, here, check these boxes. And what I realized was that they had never seen this checklist before. And so they were like, they had different approaches, like everybody's mental model is a little bit different, right? And so one of them thought they could see the same thing and they would think a little bit differently about how they would score it. And not that you want to kind of groom your reviewers and how you want them to score your study, but more like having a shared mental model of like, this is what I would expect. This particular action I would expect to be scored a 2 or whatever it is. So it may be beneficial as part of your pilot to say, here's a sample run of my simulation. We're going to go through this video together. This is how I would rate this. And so then your readers, your reviewers kind of have an idea of a shared mental model of how they're going to go through that checklist. And then for the actual study data, they can go on their own and they can perform that checklist. And the reason that that's important, it goes back to the question that was raised before about inter-rater reliability. So the inter-rater reliability is asking, if you have two different people look at the exact same video or performance, how are they going to score it? And is it reliable? Is it similar between them? Because if two people are scoring the same thing very differently, it's not a very valid checklist. But if two different people score the same thing using a checklist and it comes out pretty similar, that's a very valid checklist. So if the checklist has been validated in advance, you'll already have an inter-rater reliability reported. And that's what you can hopefully expect for your outcome. And then once your data collection has concluded, you can perform your own inter-rater reliability statistics to see if it matches up with the validated study or not. Does that answer your question? Okay, great. And then I'm just gonna see.
And Lauren, just to sort of add a little bit on that, I totally agree with a lot of what you said. Isabel brought up an important point in the chat that a tool doesn't really possess validity or not. It kind of, you can make an argument that it is valid in a certain context or possesses validity in that context. And so what you brought up a great point. Like if there have been validation studies done before, then evaluating the context that you're using it in is really important. And figuring out, am I using it in the same population and am I studying the same thing? Then you can make an argument that it possesses validity in that context, and you can use it for your study. I will say though that often there's a period of like you were saying, of calibration where you have both reviewers or however many people you're going to be evaluating using the tool to evaluate whatever you're evaluating. You'll have a calibration period where they'll all assess the same videos. You can do an inter-rater reliability or whatever, sort of how you're evaluating, how they agree before they then go on to use the tool individually. Which is different than when you're doing a validation study, in which case you have all of the reviewers review every single video scenario, whatever you're doing.
Thank you so much, Lindsay, for all that clarification, and Isabel.
Yeah, and can I just add like a specific example?
Yeah, of course.
Might be helpful. It wasn't a simulation study, but we did a study using a new tool that we came up with for clinically relevant bleeds in pediatrics. So what we did is we had 4 reviewers. And during the calibration period, for instance, all 4 reviewers reviewed the same randomly selected cases, or you can say for simulation, the same videos. And if there are discrepancies in how we scored based on that specific tool, we then all talked about it as a group and said, why did you do one thing versus another? And what do you want to do moving forward so that we're all consistent? You do that until your inter-related reliability score or kappa score, whichever one you're using, is greater than equal to some percentage, like 80% is what you might traditionally see. So that then that's a calibration period. And then during, kind of back to the original question, Dr. Gowrie mentioned, if you have 2 reviewers and there's a discrepancy, what we did in that study was we had a 3rd reviewer independently review, and everyone was a blinded reviewer, but the 3rd reviewer would review, and if they agreed with one of the other reviewers, then that would be the score that we would use. If there's no discrepancy between the 2 scores and they're consistent, we would just use the score that the 2 reviewers used. So for instance, for like using a checklist and kind of like a specific example on what to do when you have discrepancies, or what you could do if you have discrepancies.
Thank you so much, Ryan. I love all this discussion. I learned so much being in these meetings. Okay, so moving on, the clinical translational outcomes. I won't belabor this just because we're approaching the end of our time, but again, it's hard to achieve this highest level of the Kirkpatrick's model, but it's very, very highly valued. And you just want to make sure that you're avoiding confounders. So is the transfer or impact on society? Do you think you can reasonably associate that with your intervention, or is it possible there was some other intervention happening at the same time? So I'll just give a quick example. Like, I had this aspirational goal of doing this study where I designed a simulation intervention to teach cardiology topics, and I wanted to look at the our in-training exam scores in cardiology before and after my intervention. And I was like, oh, this is going to be great. But then at the exact same time I was doing my simulation study, we changed our didactics to go from like daily didactics to academic half day. And I was like, this is a massive confounder because we're going to get completely different in-training exam scores. And I cannot possibly say that this is due to my intervention because it's probably due to the academic half day structure. So just something else to consider in terms of confounding. All right, so in summary, I think the theme of this paper is an ounce of prevention is worth a pound of cure. So the more time that you spend designing your study in advance and thinking about your potential pitfalls and standardizing your study, the better your outcomes are going to be. Pilot your studies, avoid the potholes. Standardizing is so important. I accidentally wrote it twice. And just be ready to roll with the punches, because in simulation, we do our best to simulate things, but inevitably something crazy is going to happen, and you just got to be ready to deal with it. So with that, any other comments or questions? I'm going to go back to the chat here. Okay. Anybody else want to add anything? Any other questions? All right.
Lauren, there
Yeah.
was another question that just got asked. Is it possible to compare two modes of simulation intervention with two different outcome measures? And I'm curious to hear whether sort of what the thought you have is. Are you comparing one mode of simulation with one outcome measure to a different mode of simulation with a different outcome measure, or sort of cross design where you have sort of four?
This is Dr. Shakila from Chennai. This is related to my simulation research which is going on. I have two different methods of intervention in the research which I am doing. One is a virtual reality intervention. The other one is a physical simulation. The other learning goes through a physical simulation. So I would like to know if I have to do my outcome measures. Am I supposed to have the standard measures which can be applied to both the simulation intervention, or I have to have different interventions, different outcome measures for different interventions to validate it ultimately, or to compare which one is going to be the best? And my topic of the research is effectiveness of virtual reality in training pediatric peritoneal dialysis. So I'm actually comparing both the interventions now. I'm totally stuck up with exactly how to measure the outcome measures. And if I'm measuring with two different methods of standardizing both the outcome, comparing them will give us a result which is going to be of valid.
So if I'm understanding you correctly, it sounds like you want to compare two different modes for teaching peritoneal dialysis. So traditional versus like virtual reality. In which case, I think if you're trying to compare those two things, you have to figure out an outcome that is going to be meaningful, that you could assess both in the virtual reality and in traditional training, because otherwise I think you would struggle with comparing how do you compare the two outcomes to say whether they're non-inferior or one is superior to the other. Does that make sense? I'm curious if anybody else has different thoughts on that.
Yeah, no, I guess I think it would be hard to if the outcomes are different to say that one is more, based on your title, the effectiveness, and I think you're trying to prove, maybe superiority there based on the title. I think the outcome measure has to be the same, or should potentially be the same. If you can do that, and the outcome measure that you're looking at, unfortunately, can't be linked, or not can't be linked, but if you're doing one VR and one hands-on, and then you study them in the hands-on realm or the VR realm as your outcome measure, the problem is then you'll say, well, what if they're just, muscle memory and doing the same thing twice, and that's why they scored better. So that's where it becomes difficult. And maybe going back to what Lauren mentioned, is there any way you can look at, which is really hard, but trying to get to the goal, to the holy grail of research, any way you can study like patient level outcomes or something that is like applied outcomes as your outcome measure that doesn't necessarily link to the training that you're doing?
No, that's what, as far as the outcome measures are concerned in this particular context, what I'm able to assess the long-term measures like implication in practice. That can be similar in both, in whatever way I teach them. But as far as the short-term learning, that the initial stages of assessment, to be frank, I'm really stuck up, how exactly to assess in a same way, in a similar methods of assessment with a structured ASCII. I have a lot of doubts in that, whether if I'm using the similar ASCII for both the methods, because with VR we won't be able to give any muscle memory to the learner. So I have aligned some questions particularly in ASCII related to the physical simulation, and some to that. I'm really stuck up. I'm just trying to find out a solution. The initial stages of the learning, during the reaction phase and the behavior phase, comparing the virtual and the real-time simulation, I'm really yet to frame the ASCII structured questions.
I think maybe we can find some time to speak about this offline, Marlene, and yeah, we would love to maybe help you and see if we can maybe coordinate a mentor for you, because I know that is one of the other goals of this group. Okay, so maybe just I'm gonna put up our emails at the end, and if you want to shoot us an email, maybe we can work to try and find someone to work directly with you on this project. Okay.
Yeah, and then potentially we're due for another mini alert presentation in the next couple of months. So that might be a good realm to present your research more specifically to this group, and we'll try to link an expert to that. So that might be a good opportunity for you to get feedback specifically on your project.
Yeah,
quick
definitely.
comment, just from Isabel, quick comment. So we are actually working on a mentor tool. And I just privately messaged Lindsay about it as well. So we're working on a mentorship tool because we need it both for the alert presentations for Inspire, but also for the fellowship to select mentors and to self-select. We're just in the process of how to identify and self-identify mentors so that they're comfortable with being identified as such. But I can definitely help as well with identifying mentors. We have a huge list of people with what they kind of do. We're just trying to make it inclusive and comprehensive. More to come.
Thank you so much, Isabel. So in our last 3 minutes here, I just want to give a quick pitch about what's coming up next for Inspire. I know it's very, very short notice, but hopefully everybody got the emails about the diversity, equity, and inclusion proposals that are going to be due tomorrow night. And then on September 10th is the Inspire meeting at IPSSB. And I know that this is not a hyperlink that people can copy, but wait, maybe I can put it in the chat. For everybody, in case they have not signed up, I encourage everybody to join. And then our next meeting is going to be September 27th at 9:30 Eastern Standard. And I believe that our topic is going to be future simulation modalities, but I just want to confirm that. I know Michael are we still good for that?
We are gonna, I think we're confirming with Todd. The time may change slightly, but the plan, I think, will be for our September meeting to be virtual reality and augmented reality. Thanks, Lauren. Yes, and Geeta put a good note in the comments that the Inspire meeting is free. You don't necessarily have to sign up for IPSSV, although highly recommend. But you can just sign up just for the Inspire meeting, and it is free. And I hope that many of you guys will be there because it's going to be great. And Michael copied his, I will send an updated email for Michael because he actually uses his university email rather than his Gmail. But those are our emails up there, and we would love to hear from you guys about sort of anything. If you guys are in search of a mentor, that would be great. We can connect you with Isabel, how things are going. Whether this is working for you or not, we'd love to hear your feedback. And if there are topics that that should be done in the near future, I think that would be great to hear from you guys on what you would like. I know we're thinking about doing virtual reality and augmented reality. Isabel brought up a session on publication guidelines would be really great. And I think also on validation of tools might be helpful, not only if you want to validate them, but learning about the process behind validation and how it happens. So you can understand that when you're implementing your studies and using your tools.
I would definitely like to learn about that.
And thank you, Lauren. That was a really, really wonderful presentation. I learned a lot, and it's always really helpful to review everything. So thank you for walking us through that.
All right. Well, it is 11 on the nose. So I hope everybody has a good day.